Well, welcome everyone to another of Packard Children's Hospital's 20th anniversary lectures, Eating Disorders and the Athlete, Dispelling the Myths and Finding the Facts. This special series focused on the innovations that were born here at Packard Children's and have grown during our 20-year history. Feature several of our premier physicians speaking on the innovations in their field. I'm Nancy Sanchez, Manager of Community Relations here at Packard, and I have the honor this evening of introducing to you our distinguished panel. Our physician speakers this evening, Dr. Jennifer Carlson, Dr. Neville Golden, Dr. Hans Steiner, and Dr. James Locke. They've given graciously of their time and expertise to share with you their insights and innovations in the treatment of eating disorders as they apply to our young people as athletes. The format of this evening will be a series of presentations by each of our four speakers, followed by a question and answer period from the audience. Hopefully you've each received an index card. If, as time goes on, you just want to jot down any questions that come up, and at the end we will collect the index cards and we can call out your question. We'll also have a mic moving around the audience so we can pass it and you can ask your question aloud if you prefer to do that. We've also given you evaluation forms, and we hope that you will fill those out before the end of the evening as well. Additionally, though we don't believe there are any journalists here in attendance, we're asking everyone to please respect the privacy of the individuals in our audience. We do not mind news and online publications sharing the information discussed by our presenters, but any sharing of images or identifying of information of our audience members would not be appropriate, and we thank you for your understanding. Lastly, I hope you know that we have other lectures coming along. We had flyers out there. Next Tuesday evening, Dr. Sanjeev Dutta is going to be speaking on minimally invasive surgery. He's our surgeon who's really come up with Look Ma, No Scars. He's done some amazing work with reducing the psychologically damaging scars that occur for children when they've had surgery early in their lives. And that's here in the auditorium next Tuesday evening. We have an autism conference coming up in April for parents and professionals, Bridging the Gap. And in May, we have Dr. Atul Butte coming to speak on the future and personalized healthcare. Those are all available for you to register online, and we hope you would come and see us again and take advantage of those lectures. In addition, on the 26th of June, we have a big birthday party here at the hospital. It's going to be on our campus out along Quarry Road. It's a Sunday afternoon and a great time to take advantage and come and meet all of our staff and our departments and some of our partners. There's also, by the way, in the handouts, a lecture being given next Tuesday, same night as one of our other lectures. Melanie Katzman is speaking, and I think I have a copy if you didn't get a chance, The Disease of Modernization, Food Identity, and the Challenges of Consumption. So there is another lecture coming up next Tuesday if this is your area of interest. And now to introduce tonight's speakers, I'll start by introducing Dr. Jennifer Carlson. She's an assistant professor in pediatrics at Stanford University School of Medicine, and she's on staff as a pediatrician here at Lucile Packard Children's Hospital. She's board certified in both adolescent medicine and pediatrics. Dr. Carlson's areas of research interest include the female athlete triad, adolescents and eating disorders, athletes and supplements use, and the effect of sports involvement on adolescent self-esteem. She's published a number of articles in professional journals on these topics, and in addition to her research and publications, Dr. Carlson sees patients at the Packard Children's Hospital Adolescent Health Clinic at Castro Commons. A recipient of the honor roll for teaching at Stanford University Medical Center, Dr. Carlson's here this evening to address the medical complications of eating disorders in athletes. So please welcome Dr. Carlson.
Thanks so much and welcome. So to start off our series of discussions, I'll be focusing on the medical complications of eating disorders and the athlete. So just to talk about what I'll be discussing over the next few minutes, really just want to talk about what is an eating disorder, and talk about some of the risk factors for eating disorders in athletes. We're going to talk about some symptoms of eating disorders, the medical complications of eating disorders, and finally, what do you do if you suspect an eating disorder in someone? The learning goal is to identify the symptoms of an eating disorder, particularly as it relates to the athlete. So, just sort of jumping in, so what is an eating disorder? An eating disorder is it's a group of disorders that are characterized by abnormal eating patterns that compromise the physical health and the emotional well-being of the individual. And there's three, at this point in time, there's three kind of broad categories that we talk about. So we talk about anorexia nervosa, bulimia nervosa, an eating disorder not otherwise specified, which is sometimes referred to as EDNOS, sometimes to EDNOS. All of these disorders do have very specific criteria in order to meet the diagnosis, which I don't really want to go into at this point, but just want to give you some of the general characteristics of these. So for anorexia nervosa, this is characterized by a low body weight, a fear of weight gain, and often an inaccurate perception of one's own body size, body shape, body weight. Bulimia nervosa is characterized by binge and purge episodes. And a binge, how we define it, is that it's eating a large amount of food in a discrete amount of time and really a sense of being out of control while doing it. So it's not eating an extra cookie or having an extra bowl of cereal. It's really kind of a larger amount of food and that sense of being out of control. Following these binge episodes, it's generally some kind of compensation, so some kind of purging. And typically people think about vomiting with bulimia, but it doesn't have to be vomiting. It could be using laxatives, it could be using diuretics. With a lot of our athletes, it could be exercise, so going for a 5-mile run after consuming more calories or doing 5,000 crunches. And then eating disorder NOS is a pretty broad category of people who may not meet all of the strict criteria of anorexia or all of the strict criteria of bulimia. So they get this other diagnosis of EDNOS. But just to really stress, it doesn't mean these patients are any less serious or have any less severe complications than those who have anorexia or bulimia. And I finally just wanted to point out disordered eating, which I think is a term that we use a lot and that you hear a lot about. But what exactly does it mean? I think it's used in different circumstances in different ways. But generally, it's sort of on the spectrum of abnormal eating patterns that may not actually meet the diagnosis or the criteria for a full-blown eating disorder. So something that's not quite normal, but hasn't quite gotten to the point of being diagnosable as an eating disorder. And having disordered eating definitely is a very big risk factor for going on to develop an eating disorder. And this is what we see, I think, a lot of our athletes in clinic. There's often a huge energy mismatch, which I think Dr. Golden will be talking about a bit. But just the amount of calories coming in, it may not be that someone's restricting to only 400 calories a day. Maybe they're eating 1,800 calories a day. But the amount of exercise they're doing, the amount of energy that they're using, is just causing this huge offset. And I have an example of this. So this is a table that some of our dietitians can use that basically shows some of just the estimated caloric needs of individuals. So don't want to get too caught up in all the numbers, but this is for females, and you can see the different ages on going down the side. So for example, a 15-year-old who maybe weighs about 115 pounds and is a very active would need about 2,900 calories a day in order to kind of maintain weight. And again, this is kind of an average and estimate. This isn't for every individual. So you can see that if somebody is maybe consuming 2,000 calories but requiring 2,900, you have that huge mismatch, which eventually can lead to medical problems. So who does it affect? So the prevalence of eating disorders in adolescents. With anorexia nervosa, the numbers are about 0.5 to 1%. With bulimia nervosa, 1 to 2%, and EDNOS, which is not as well described as either bulimia or anorexia in terms of the prevalence, is estimated to be anywhere from 0.8 to 14%. By far, in our clinic, we find this is the majority of our patients probably have this diagnosis compared to the other two. Males do have eating disorders. About 5 to 10% of all patients are male. And basically, all ethnicities, all socioeconomic groups are affected. There really isn't any group that's spared from having a diagnosis. So risk factors for eating disorders in athletes. So some of the things that maybe predispose some of the athletes or things that we get worried about are participation in particular sports. And some of these sports include those that emphasize appearance, or what many people would call aesthetic sports. So sports such as ice skating, ballet, dancing, where it's really that kind of body image that can be very important. Weight requirements or weight classes. So for example, lightweight crew, wrestling, where there is an emphasis on attaining a certain weight and keeping it often within a fairly narrow range. Sports that emphasize the individual rather than the team, and endurance sports. Endurance sports, just because it's also a huge, often caloric demand. So to participate on a cross-country team, you're just needing a lot of calories to fuel that type of activity. Other risk factors, a belief that a lower body weight will improve performance. And I've seen a number of patients who've been admitted to our hospital who say that, at one point there was a coach who told them if you lost 5 pounds, your sprint time would be quicker. And while for some individuals that could be true, 5 pounds can sometimes evolve to 10 pounds, 15 pounds, 20 pounds. And at some point, a body just crashes. It just can't do that. Sports where you're focusing solely on success and performance rather than maybe the enjoyment of the sport or the enjoyment of being on a team. And some other risk factors, low self-esteem, fear of failure. There's definitely some genetics that are involved. I mean, there's multiple factors that go into the development of eating disorders, but there are definitely genetic components. And then social influences as well. So family and peer pressure about athletic performance. If this is really the only thing people talk about, perhaps that's going to be more stress and predispose somebody to developing an eating disorder. So talking about symptoms of eating disorders, and I want to stress with this that not one of these things means somebody has an eating disorder. These are sort of red flags for us, and it's really a constellation of symptoms that makes us more concerned. However, some of the things that we do see are abnormally slow heart rates or low blood pressure. And heart rate can be a particular issue with athletes in terms of how do you interpret it. Because it's definitely true that athletes do have lower resting heart rates than non-athletes. However, we generally say our cutoff is about 50. So heart rates above 50 are considered stable. Heart rates below 50 are considered unstable. And there's not a lot of great research and a lot of great information about what are baseline values, particularly in adolescence. However, the information and the research that is out there is generally it's above 50 as kind of a resting heart rate in even well-trained athletes. Other symptoms that we can see, dizziness or fainting, dehydration. You can see cold hands and cold feet and cold intolerance. Cold intolerance meaning somebody sitting in a room and just can't get warm while everybody else is feeling fairly comfortable. You can have chronic irregular bowel movements and constipation. Loss of periods, which again I think is very critical to talk about with our female athletes, and Dr. Golden will be talking about this more. But if somebody is having adequate nutrition, even if they're training at very high levels, they should be able to maintain periods. So some people do feel like, oh, if I lose my period, that means I'm really working out hard enough. And that's definitely a myth. So you should be able to maintain periods with proper nutrition. Frequent injuries, frequent fractures, the loss of muscle, weakness, dry skin, dry brittle hair, and then tooth decay and staining. This last one is generally with people who do vomit, and you can see this. And then for our athletes in particular, some of the things that you can see with athletic performance, you can see decreased energy, decreased speed, decreased concentration. The body's just not getting the fuel it needs in order to perform at those kind of higher levels. You can have a longer recovery time after workouts. An individual may have a real difficulty with tapering, like at the end of the season when you're tapering for the big swim meet or the big cross-country meet. And maybe an individual just can't really cut down on their mileage or take days off. So it's hard for an individual to have that rest day. You might see that individuals are going for prolonged training or an additional training. So after swim practice, they're coming home and going out for an additional 5-mile run. Those are kind of red flags to us. And then finally, a preoccupation with food. So this could be preoccupation with one's own food, with food around them. And we see a number of patients who have gone from eating a regular diet to becoming a vegetarian, or eating a vegetarian diet and going to a vegan diet. And while there's lots of other reasons that people do choose to make those types of dietary choices, we do get concerned when it's in the setting of all these other symptoms, because it's often a way to cut out higher fat, higher caloric foods. Excuse me. So some of the medical complications. To stress, eating disorders are serious. They can be lethal. They have the highest mortality rate of any mental illness, about 20%. And that's not an adolescent rate, so that is over kind of a longer age range, but it is very high. And compared to the general population, if you look at adolescent and young adult women with eating disorders, the mortality rate is 12 times greater than the general population, and a suicide rate that's 75 times greater than the general population. So it's definitely, a concerning issues. With these couple slides, I just wanted to stress that the medical complications of eating disorders they affect the whole body. So there really is not any system that's not spared or could not be spared with these disorders. So some of the complications that we're more concerned about and that we're worried about and following, especially when we're seeing people in clinic or seeing people in the hospital, is heart failure and irregular heart rate. So there are some rhythms that the heart can get into that could potentially lead to the heart just stopping. Anemia, which for some of our athletes are a big issue. If you're having reduced red blood cells, that can actually affect performance, particularly when you're talking about endurance sports. Reduced muscle mass, and there have been studies that have looked at actual hearts, which are muscle, and have shown that there is a thinning of the muscle within the heart. You have reduced bone mass, which in older individuals would be considered osteoporosis, and can lead to increased fracture rates. We see delayed gastric motility, so basically everything's moving a lot more slowly through the GI tract, and that can lead to a feeling of bloating, distension, constipation. And those are real feelings that patients are having, which can sometimes make it even more difficult then to increase consumption because they're already having so much discomfort. Electrolyte imbalances occur, particularly with vomiting. This can also then just kind of worsen heart arrhythmias that might already be going on. More recent research has looked at brain changes and that there are structural brain changes with malnutrition. It's still a little bit unclear how this relates to functional ability of the brain, but this is one of the things that that's I think being looked at more recently. And then finally, in some of our younger patients, you can see delayed puberty, you can see growth retardation, you can see short stature. And while with proper nutrition, we do see catch-up growth, we don't know if people will catch up to where they could have been if they never had this period of malnutrition. So if you suspect an eating disorder in a friend, a teammate, a child, what to do? Contacting a health professional, and ideally one who has knowledge and experience with eating disorders. Not every general pediatrician, general family practitioner, or internal medicine has the training for this. It's not necessarily in everybody's kind of forte. So finding someone who has some experience, and that can be through an adolescent medicine program, a specialty eating disorder program, psychiatrist or other mental health professional, and trying to get that person tied in and get the help and resources to get diagnosed and treated and help for recovery. So I think we'll take questions at the end, but thank you so much for your attention.
Thanks, Dr. Carlson. And now I'd like to introduce Dr. Neville Golden. Dr. Golden is the chief of the Division of Adolescent Medicine at Lucile Packard Children's Hospital and the Mary Elizabeth Kendrick Professor in Pediatrics at Stanford University School of Medicine. He's a board-certified pediatrician and adolescent medicine specialist with more than 25 years of clinical experience. He's a nationally and internationally renowned physician for his research on the medical complications of eating disorders with a focus on the management of amenorrhea and osteoporosis in anorexia nervosa. Dr. Golden will present the myths and facts of what it means to be a healthy athlete. Thanks, Dr. Golden.
Thank you very much and welcome. Good evening, everyone. In 1971, the National Organization of Women sued the state of New Jersey to allow young girls to play baseball. And the following year, in 1972, Title IX of the Education Amendment Act was passed, and that mandated that girls and women have equal opportunities to play sports. Since then, the number of young girls participating in sports has increased exponentially. In 1970, a single woman entered the New York City Marathon, and she did not complete. In 2010, there were 16,300 women who entered, and all but 100 completed. Things have changed. Exercise is good for you. It promotes health, fitness, and longevity. It increases cardiovascular health. It increases muscle strength. It prevents obesity. And you feel good when you exercise. And in the vast majority of cases, the benefits of exercise far outweigh the small risks of injury or development of the female athlete's triad. But in 1992, the American College of Sports Medicine coined the term the female athlete's triad. And this term was redefined in 2007. And the triad consists of 3 interrelated conditions. The first one was called disordered eating and is now changed to be named reduced energy or low energy availability. And it refers to taking in inadequate intake for your caloric needs. Some of these patients have eating disorders, but not all do. Some were told to lose 5-10 pounds to improve their performance, as we heard earlier. But some of them may just be eating an inadequate amount of food in order for their energy expenditure and may not realize the demands of their sport. As a result of that, they develop amenorrhea, lack of menses, or now called menstrual irregularity, to try and encompass a whole spectrum of disorders. Because in the lack of energy, non-essential functions such as reproduction are switched off and they become amenorrheic. And then they develop osteoporosis, very similar to postmenopausal women who also have amenorrhea in the face of a low estrogen state. So these individuals are susceptible to stress fractures, and many of the stress fractures in athletes are not because of overuse, but because of the female athlete's triad. This is an example of a patient of mine. This is a young girl who was 20. She was a triathlon competitor, working out for 2.5 hours a day. She was an athlete who loved her sport, and she came to me because she was amenorrheic for 2 years. She was of normal weight, and she did not have an eating disorder. And this is a bone density scan. We call it a DEXA, and this can show, this over here is the normal, plus 2 standard deviations, and minus 2 standard deviations. Now, any drop in bone density of more than 1 standard deviation doubles your fracture risk. This young girl had a standard deviation way below 2. It was around about 3.8, and she had the normal bone mass of an 18-year-old woman, 80. So this young person who thought she was healthy clearly was at risk for osteoporosis and fractures. So myth number 1, amenorrhea is not an expected part of rigorous training. It should be a red flag that there's something else going on. So that's the first myth we should try and dispel. How common is it? Well, it's certainly very common in elite athletes, and this is a recent study from Europe, from the United Kingdom, looking at 44 elite athletes, and you can see that menstrual irregularities over here was present in 64% of these athletes. They also evaluated for eating disorders, but I read that article many times and I couldn't assess what percentage of patients actually had eating disorders here. But the strength of this article is they also measured bone density, and you can see that 1/3 of them actually had low bone mass. These are elite runners, and 16% met all 3 criteria. Now that is elite athletes. What about high school students? This is a study of the female athlete triad in high school students in California. These were 6 high schools in Southern California, 170 patients. And you can see that disordered eating was present in about 18%, menstrual irregularities in about a quarter, and low bone mass in about a fifth. Most patients did not meet all criteria, but you can see that any 1 or 2 of these criteria were pretty common. So it's not only restricted to elite athletes. Myth number 2. The female athlete triad does not only occur in elite athletes, it can occur in high school athletes and also recreational athletes. This is particularly important in the adolescent years because it's these years in which peak bone mass is accrued. Over here you can see that during the adolescent years one reaches peak bone mass, and thereafter there's a decline of about 1 to 2% a year until menopause in the case of women, or equivalent of men a little bit later, and then there's a rapid decline. Now, if an individual has an illness, it could be an eating disorder, or it could be the female athlete triad, she may not reach peak bone mass. Just say she stops her sport, goes off to college, but she may be at risk for reaching this fracture threshold many years before her counterparts. So we take this very seriously. So what can we do about it? In order to understand what to do, we need to understand what are the factors affecting bone mass. About 70% of the variance you cannot do anything about. You can't change your gender. We know that males have higher bone mass than females. We know that blacks have higher bone mass than Caucasians. And we know that if you have a family history of osteoporosis, you're more likely to develop it. But there are things we can do something about, particularly diet, the amount of calories we've heard, also calcium, vitamin D, soda consumption. There are great studies from the Boston area to show that people who drink more soda, especially young girls, are much more likely to sustain fractures, probably related to a decreased amount of milk consumption. Body weight is probably the most important determinant. And then your hormone status, both estrogen and androgens, such as testosterone, are necessary for bone health. I'll talk about exercise in a second. And lifestyle choices such as alcohol use or smoking both act negatively on bone mass. So these are the most recent recommendations, and they are really recent, they're 1 month old, by the Institute of Medicine. And it's recommended for a young athlete, such as a child or an adolescent, they require 1,300 milligrams of calcium a day. Now, if you think of a glass of milk or a serving of cheese, that's about 300 milligrams. How many adolescents actually are having 4 to 5 servings of milk a day? Not many. Vitamin D, we're recognizing the importance of vitamin D, and now it's recommended that young people take 600 international units of vitamin D a day. That's actually 3 times the amount that was recommended 5 years ago. And we know from studies in adolescents that supplementing with calcium and vitamin D actually increases bone mass. We don't know that in patients with eating disorders, though, but we do recommend it. Body mass is important. Your weight is important. Bone is a living substance, so every time you step on a limb or you jump, you can actually promote bone formation. And so we know that people who weigh more have higher bone mass than those who weigh less. Clearly, people with eating disorders, especially those who are of low weight, are at high risk. In anorexia nervosa, we also know that increasing weight is associated with an increase in bone mass. What about exercise? Exercise is actually protective of bone mass. So this is a great study in college athletes, and you can see here college athletes who did a weight training program for about 8 months increased their bone mass, as did runners. These are all weight-bearing or resistance exercises. Whereas sedentary athletes over here lost bone mass in that same amount of time. So exercise is protective, especially weight-bearing exercise. We know in female athletes who have regular menstrual cycles, shown here on your left, bone mass is significantly higher than regular controls. But that positive effect, that benefit is lost over here once those same athletes exercise to the point where they lose their periods. So exercise is protective, but not if you lose your periods. So what about hormones? If this is like postmenopausal women, maybe if we give young athletes hormones, that will help and that will protect their bone mass. Two elegant studies I'm just going to share with you. One that actually was conducted here at Stanford, but enrolled patients from different schools across the country, 150 competitive female runners, and they were randomized to receive either oral contraceptives or not, and they were followed for 2 years. And the beauty of this study is not only were they followed, but if they gave a history of a stress fracture, that was actually documented by doing a scan or an MRI. And what they found is that over a period of 2 years, prescribing the pill or any form of contraception did not protect against bone mass. A similar study conducted in a smaller number of patients in New York City by Michelle Warren in ballet dancers showed a similar effect, that for 52 dancers, 24 of whom had amenorrhea, lack of menses, those who were given hormones did not increase bone mass over a period of 2 years. So it does not help, or there's no evidence that it does. So my final myth to dispel is that hormone replacement therapy increases bone mass and protects bones in female athletes. It just isn't true. In fact, there are many of us in the field who feel that it actually will mask resumption of normal menses, which actually could be a clinical sign for that individual, indicating that she is at a healthy weight. So just to end off, what can we do about this? I think first of all, prevention is important. It's important to educate our athletes, their parents, their coaches about the dangers of eating disorders, and also what the female athlete triad is. And that's actually what we're doing here this evening. I think it's incredibly important to discourage preoccupation with extreme thinness as an ideal. We get this thrown at us from the ads that we see, televisions, commercials, the movies, and many of the pictures we're not seeing are actually not real. We know that. They are airbrushed. It's important to recognize that optimum weight for true health may not be the same weight as the so-called thin ideal, and it also may not be the same weight for supposed peak performance. I think it's important to recognize this condition and to know that amenorrhea should be a red flag. It's not a normal part of training. And to intervene early. If there is a concern, I think individuals with a female athlete triad should be evaluated for possible underlying eating disorder by professionals who have expertise in the management of these diseases. And then what do you do once you've made the diagnosis? Say you have the diagnosis and that patient does not have an eating disorder. Well, the first thing to do is to try and increase energy availability. Dr. Carlson showed you the energy requirements of some of these sports. Our swimmer, right? Michael Phelps, 12,000 calories a day he required. And he won a couple of gold medals. You require that amount of energy if you're doing that amount of activity. So if someone truly has the female athlete triad and no underlying eating disorder, they will be amenable to increasing their caloric intake. If that doesn't work, you may have to reduce the amount of training, cut down on exercise, and that's very hard to do, especially in a competitive athlete who's being pushed perhaps by her parents, by her coach, or by herself. And people don't want to give up their sport. I would encourage weight-bearing exercises, such as free weights or jumping activities, as opposed to swimming or cycling. Some patients may need to gain weight. They may need to gain 5 to 10 pounds. And then we routinely recommend 1,200 milligrams of calcium a day and 600 international units of vitamin D. But I would not put my patient on a pill, leading that individual or her family to believe that this is going to be a panacea. It really is not. Some people are prescribed the pill for other reasons, and that is fine, but the pill itself does not increase bone mass. So I'm going to end there and hand this over to the next speaker, and we'll have questions at the end.
Thank you, Dr. Golden. Our next presenter is Dr. Hans Steiner. Dr. Steiner is Professor Emeritus in Psychiatry and Behavioral Science in the Division of Child Psychiatry at Stanford University School of Medicine. He's recipient of the Lifetime Distinguished Fellow Award of the American Psychiatric Association, as well as the recipient of many other awards, including the Outstanding Mentor Award received 6 times from the American Academy of Child and Adolescent Psychiatry. As one of the founders of the Eating Disorders Program here at Packard Children's Hospital, Dr. Steiner has published widely on tonight's topic, including his recently published Eating Disorders Fast Facts and the Handbook of Developmental Psychiatry, both for clinicians. Dr. Steiner consults with collegiate athletic teams and has an interest in adaptive styles of collegiate athletes. He's also the founder of Pegasus Physicians here at Stanford, which is a group for physicians who write creatively. Dr. Steiner will describe the realistic picture of athletes and the unholy triangle, and how parents, coaches, and mental health professionals fit into the picture. Thanks, Dr. Steiner.
Thanks, Nancy. We're hopefully going to give you a sort of little bit of a map. When do you need to be particularly watchful? When do these problems arise in the course of a juvenile athletic career, especially as they're headed towards elite athleticism? And I'm going to give you a hint as to what some of the mental characteristics of elite athletes are. And for those of you that are poetically inclined, this poem, which I'm sure most of you have at least heard of, if not read, captures what I'm going to say. It's a poem by Rudyard Kipling. It's called If. It's on the web. And basically what he's talking about is a giant invitation towards stoicism in the face of adversity, which is very fitting for elite athletes. That is one of the characteristics that makes them elite athletes, but it's also a characteristic that puts them at risk. And I'm going to show you how that works. Our goals for this part of the presentation is I want to give you a realistic picture of risks and benefits in this cohort. I want to describe to you this tendency towards stoicism, which coaches and athletes refer to as mental toughness and ability to focus. It's it's a different side of the same coin, which then incurs the risk of being somewhat oblivious towards things when they don't go so well. And that means coaches, parents have a very important role to play with athletes, because they're somewhat blinded to the ill effects of what's happening to them, and sometimes will actively contradict and even fight with you as you're trying to present the idea that something is wrong. Unfortunately, I call it the unholy triangle, because parents are sometimes obviously also very invested in having their kids succeed for whatever reasons. And so they tend to sometimes turn a blind eye. And coaches for sure do, especially if your kid is a kingpin member of a team. They will very often turn a blind eye because they need that kid on the team to win whatever championship they're about to win. So I'm going to give you my real credentials. This professor stuff really doesn't matter all that much in this context. I'm going to talk to you a little bit about the issues. I'm going to show you some data. We've done a whole series of studies with high school student athletes and Stanford athletes. And these are elite athletes by any definition that I know. These are world record holders, Wimbledon winners, et cetera, et cetera. So you see in a concentrated way what it's like to be an elite athlete. And you have to look for that in your kids as they're headed in this direction. And then we're going to sort of talk a little bit about, so what are the implications for parents and mental health professionals, coaches, and pediatricians. So what are my real credentials? Number one, I've taught a course at this university at the undergrad level that's geared towards the athletes on campus. It's called The Mental Health Dimensions of Sports. It's gone on for 10 years. I know these kids very, very well because they're my pupils. I also work with a lot of them on performance optimization and mental toughness, and I work with all kids from all kinds of different teams. I sometimes work with teams, so I know what it's like to perform at the highest level of achievement and what it takes mentally to get there. I'm a doctor, and I've treated a lot of these athletes, and what you'll see is what happens to them as they become injured or some intercurrent events take place that throw them off the trajectory that they're on. That's when eating disorders and other mental health problems become an issue. For girls, it's eating disorders. For boys, actually, it is what would you guess? Come on, people. What do boys struggle with when they fall off the wagon as athletes? Okay, I'll ask you it again at the end of the presentation. Then there was an answer right there. What did you say? No, okay. All right.
We all have girls.
Well, there you go. All right. As I said, we've done a series of research studies on it. I think there's a paper out there, our latest one, that'll help you follow up on some of the things that I'm talking about. And then obviously I'm an athlete myself, because you can't work with this population. If you don't have a background in this, you do not understand what they're going through and how serious it is, how short their careers are, how challenging, and how tough. And then, I have a sort of family history behind all this that's a little more complicated. If you want to hear about this, you've got to buy me a cup of coffee at Starbucks, and I'll get into that. All right. If you want to follow up on some of the things that I'll say, there's a website, a private website I have, the hansteiner.com. That's where you get all the reprints and my track record. So what's the problem? The problem is this. It's this pyramid. To go from high school football into the pro ball level, these are your chances roughly of making it. Okay? Interestingly enough, so they're very, very small, obviously. Interestingly enough, it does not matter what sport you pick. And I'm going to pick just one for comparison. The numbers are very, very similar. The pyramid is very, very similar. And I'm picking tennis here because I'm a tennis player and I love tennis and I work with the tennis teams here. It's about the same. The point is that you're putting in a lot of time, a lot of effort, but to really get to the pinnacle, your chances are very, very small. So the message number one from you people, from you parent people, to these little kid people has to be, enjoy the ride. Don't think you're going to break the world record here and there. If that happens, that's great, but enjoy the ride to get there. Because chances are that's what it'll be. Now, what the coaches say, what it takes to get from one level to the next, and this gets us back to this topic of what kind of mental characteristics do elite athletes have to really become elite. The coaches say, obviously, as you're trying to get into high school sports, what it takes is talent, coordination, toughness, fitness, somewhat strength. You're not quite at the pinnacle of your physical development yet. That's yet to come. To really maximize your physical prowess then gets you from the high school level into the collegiate level. But to get from the collegiate level to the pro level, or the Olympian level, if you will, you need to be really, really mentally tough. You need to have that stoicism about meeting triumph and disaster with the same equanimity. And what is this? What does this actually look like from a psychological point of view? And how does it relate to mental illness and eating disorder in particular? These are the two samples we studied. I will not torture you with all the numbers. Believe me, they're representative. These are the students from Stanford over here on the right, and then on the left, the local high schools, Pally and Gunn, which are feeder schools for Stanford and similar types of institutions. And a lot of elite athletes, Jim Harbaugh, have come from that school. What kind of developmental issues do you face from a mental health point of view as they're sort of going through this adolescent, young adult phase. That's what we're talking about. Well, it's a whole host of issues, and most of them are incredibly important in terms of setting up your life. So athleticism, which is very time-consuming, occurs in the context of having to set up a whole bunch of crucial developmental tasks that you have to pay attention to. Otherwise, things are not going to go so well for the rest of your life. You have to choose a career, you have to choose a partner, you got to exit from your family of origin, et cetera, et cetera, et cetera. So let's just quickly look and see how the life of a high-performing elite-level athlete, what's it actually look like, the daily life? And we're going to group it into five domains of functioning: academic, vocational, bodily maintenance, recreation, and interpersonal, being with friends, being with family. And then you have a sort of supernatant category, a psychological, reflective, thinking about who you are, whether you're doing the right thing, et cetera, et cetera, et cetera. And we're going to give you, these are now the number of hours that a Stanford student athlete spends per week on the average. This is in aggregate over the last 10 years in each one of those categories. And what you see is they spend a lot of time, this is the first sort of orangey column, in maintaining their physical fitness, as they must. I mean, they just got to keep the engine going, they got to eat, they got to sleep, et cetera, et cetera, et cetera. But on top of that, the second column then, they spend an extra, 18% to sort of push themselves the extra mile, to get that extra fitness. That's a good chunk of time, if you really think about it, those two added together. About 34%, or 1/3 of their time, they spend in academic pursuits, because very often, of course, athletes are also very excellent students. The teachers know that, the kids know that, the parents know that, so the pressure comes from that area too. Leaves now, now all of a sudden we see a sharp drop. Leaves now about 4 to 5% of your waking life to hang out with friends and family in a fashion that has to do with just being friendly and just relating to people. Leaves 2 to 3% unstructured time, and leaves less than 1% to be reflective. Now put that together with your propensity towards stoicism, blowing off negative things, not focusing on who you are, and all of a sudden you can see where this is going, right? There is no time in the week, really, to kind of think about what is happening to you. So it's not that they necessarily always just want to deny symptoms of an oncoming athlete triad, female athlete triad, or an eating disorder, is that there really is not simply time enough in their life to do so. It's your job to kind of get them there. You have to be watchful, as do the coaches, obviously. So far, that's sort of a little bit the scary news. Now I'm going to give you some really good news. What's the impact of actually being an athlete? You always have to separate out girls and boys. It's somewhat different. This is a high school sample, and what we're looking at is girl athletes, girls that are non-athletes, boy athletes, and then boys that are non-athletes. We have an instrument that essentially measures total mental health risk, not specifically eating disorders. And what you see immediately is that the athletes have it over the non-athletes. In other words, as they're engaged in high school athleticism, they in fact have lower risk than their age-matched cohorts. The other good news is that if you take something that we call approach coping in psychiatry, do you take the bull by the horns? Do you try and solve problems directly rather than avoiding them? The athletes have it over the non-athletes. That's a good thing, right? That's one of the benefits of doing athleticism. You're learning something about life and how to handle it well. In terms of grade stress, again, the athletes have it over the non-athletes, meaning that although they're all immersed in highly demanding educational environments, and Gun, let me assure you, are one of the most demanding educational environments that I know, especially Gun, they still managed. It's people that are busy and are good at being busy and have high levels of skills, managing time and busyness, do well. They do better than the non-athletes. So what's the problem? Well, they also handle parental pressure better than the non-athletes. So overall, you see this really nice positive picture, except now here it comes. They have a much higher injury rate than age-matched norms. And why that is important, because that is the proximal trigger for problems. That is, your kid, when they are in this activity, when they're most vulnerable, is when they have gotten hurt doing what they love doing. Because then all of a sudden, caloric requirements drop dramatically from 12,000 a day to 2,000 a day. Their mood states are usually impacted. They sometimes have something that we in psychiatry we call post-traumatic stress disorder. It's like being a Vietnam veteran or a veteran of another war. And now put this together with an emphasis on stoicism and focus, they will underreport all these things. So again, it's your job, it's the coach's job to know that when my kid got hurt, now watch out. The boys go for what? Anybody know yet? What are they going for? What? Yes, yes. Give that woman a bottle of champagne. Thank you. Drugs and alcohol, and the girls, by and large, go towards the eating disorders. So that's the bad news. And you cannot turn a blind eye, and your coach cannot turn a blind eye, and you have to be the advocate of your child in this unholy triad. And you have to sometimes battle with your kid because they have they've invested an incredible amount of time. They want to succeed in the worst possible way. An injury might prevent that, and so they might fight with you about what the consequences are of that injury. All right. If anything, the whole thing gets more pronounced as they enter Stanford. This is now a comparison of high school students. These are the orange guys, and the green guys are the Stanford students. As they progress into our system, the pressure experience, the stress experience gets larger. They don't necessarily manifest more problems when they come to us, but they're a little primed. If anything goes wrong, now it really goes wrong. Now, we've done actually a probing study, and I won't torture you with all the instruments, but basically what we did is we sort of simulated clinical exams in elite athletes that we randomly selected from our 800 kids. And we actually did not find a very high number of them to be ill. There was only, in the 60 we examined, there was only really one bulimic girl, and that was it, which is about 1%. That's about what it is in the general population. Now, the cautionary note here is that if you are an athlete at Stanford, chances are you will have dropped out from the athleticism if you're struggling with one of these problems. To be an elite athlete at this level and be bulimic, anorectic, EDNOS, or even athlete triad is just simply not possible. You cannot do that. So you wouldn't necessarily look in the active athlete pool, but you would look in the inactive athlete pool, or the kids that have been deselected. That's where, chances are, that's where you'll find much higher rates of problems. So I'll skip that. And then just a final thing that you can also do yourself in the comfort of your own home, or if you want to, you can do it here. It'll be a little funny looking. But are there any sort of biological, physiological characteristics that map onto this stoical attitude, ability to focus, ability to ignore negative events, to perform under pressure? And the first indicator is this one. Resting heart rates in Stanford athletes are on the average 61 beats per minute. That compares to about 76 beats per minute in age-matched norms. So they're considerably below, meaning they don't have a lot of sort of negative activation, stressful activation in conditions of rest. If you then ask them to perform a small challenge task, and what usually is sufficient, you just, after sitting down for 5 minutes, you stand up and take the pulse for another full minute, they upregulate a little bit, but not all that much, 12 beats per minute. If any one of us well, there's probably some athletes here, but let's see if I do this. It's 30 beats per minute. That goes up. So clearly, they have something in their physiology, in their heart regulation, in their stress regulation, that makes it possible for them to very quickly settle into adversity and actually habitually ignore negative information and stressful information. And what's that look like psychologically? Well, here you go. The scales that you want to pay attention to are those last two ones. On the whole, they have less negative. These are now Stanford athletes and non-athletes. So this is a fair comparison because they're all Stanford people. They're all high achieving. They're not your average Joe Blow from an academic point of view. But one has this added load of being an athlete or privilege of being an athlete, and the other one doesn't. They tend to have fewer negative problems, negative emotional arousals. They tend to be very strongly self-regulated. They're happier. Their self-esteem is higher. And here come the two variables that you got to watch. And that is, they're both variables that we call minimization of negative events and stressful events. They have different labels in the literature. They're actually described in the paper you have out there. And the point is that both of these variables, on the positive side, enable you to face triumph and disaster and treat the two imposters just the same, to just go forward in the face of adversity. But they also put you at risk because when you're injured, you're not paying enough attention to the injury. When you're developing signs, incipient signs of eating problems, you tend to minimize or not even see them. When you miss a period, you don't report it. And so again, that gets us back to the unholy triad of which you are all part. You have to be vigilant. You have to be the advocate for the kid. And that is it. All these references that I've listed here are on my website. You can grab all these papers. They're specific to athletes, Stanford athletes, and high school athletes. And it's basically the message that I've just given you. Thank you so much.
Thanks, Dr. Steiner. And now it's my pleasure to introduce to you Dr. James Locke, who is the psychiatric director of the Comprehensive Eating Disorders Program here at Lucile Packard Children's Hospital. He's a professor in the Stanford Department of Psychiatry and Behavioral Sciences and Pediatrics. Dr. Locke is a board-certified child and adolescent psychiatrist specializing in the treatment of children and adolescents with eating disorders. He's a nationally and internationally recognized expert in the psychiatric treatment of child and adolescent eating disorders and the author of numerous articles, as well as 6 books on these subjects, including Treatment Manual for Anorexia Nervosa, a Family-Based Approach, Help Your Teenager Beat an Eating Disorder, and Treating Bulimia in Adolescence, a Family-Based Approach. Dr. Locke is here tonight to talk about the Comprehensive Eating Disorders Program here at Packard Children's.
Thanks, Nancy. I'll talk quickly because it's just a little bit just to put the context of what we do here at Packard. When I came to Packard, those little animals were still just wires. It's nice to see them growing their bodies. So our mission here is to provide comprehensive clinical evaluation of patients from about age 10 to 22. So we take care of elementary age children all the way through college here, at least the undergraduate years. we try to provide state-of-the-art medical and psychiatric treatments based on evidence, which makes us unusual in the world of eating disorder treatments, because basically most programs operate with a pretty eclectic and opinion-based rather than evidence-based strategy. We are a place that trains future clinicians and researchers, and we're always trying to be generative in our processes. And our research is directed towards clinical and translational efforts in eating disorders and related conditions. And as this particular evening is about promoting community awareness about eating disorders, just a word on that. Eating disorders are one of the, although advertised quite often on the covers of magazines, actually one of the most understudied areas in terms of treatment and evaluation of the problems associated with them, of all the psychiatric disorders, especially severe ones. Our program was founded by Hans Steiner and Iris Litt in 1979. I think it makes it the oldest one, certainly on the West Coast, and I think it may be the oldest continuously operating program like it in the country. It's always been a collaborative effort trying to address the intertwining problems of eating related symptoms in the brain, body, and mind. We have a wonderful collaborative group of clinicians from all parts of the hospital working with us. We serve a large geographic area. This just gives you a picture of where people come from. This is actually where most people come from, but we have patients from Japan and Korea and England, a lot of other, from time to time, people come here as well. The program consists of three components, really. A relationship with community providers who refer patients to us for evaluation, and then in some cases for outpatient and inpatient treatment. We have the Comprehensive Pediatric Care Unit, which used to be in this building, but now is down in Mountain View at El Camino Hospital, where we have leased space. It's a 15-bed multidisciplinary program. It's a pediatric service really trying to address what happens when things go terribly awry physically as a result of eating disorders. So the kinds of things that Dr. Carlson spoke about. The outpatient program is again, a collaborative effort between adolescent medicine and child psychiatry, where the mental health treatments are offered over on Quarry Road, just down the road from here. And in Mountain View, the adolescent medicine service provides ongoing medical and nutritional evaluation and treatment. We've evolved in the time since I've been here. As we've learned more about eating disorder programs and eating disorder care, we really used to be predominantly an inpatient program. Now most of our patient hours are spent in an outpatient treatment setting as opposed to inpatient. In my time, the length of stay has dropped from about 60 days to 9, and that's the last 17 years. If Dr. Steiner was to tell you how long they were when he was first here, it would be months and months we'd be talking about.
Just we're slow.
We also learned an awful lot about the value of parents and families and helping their children, particularly their adolescent children with eating disorders, and that has really been a part of a larger evolution at Packard and family-centered care, but specifically in the area of eating disorders, helping parents to understand the problems that their children are facing and finding ways to facilitate their recovery has been a major emphasis of our research and clinical programs. So we have an outpatient program, as I said. The inpatient, what we do in the outpatient program, we do 3 evaluations, new evaluations a week in the outpatient program. They come to our clinic over on Quarry Road for 2 hours. We meet with the patients and their parents, and then they go to the Mountain View for the medical and nutritional assessments. We may do ongoing consultation or just one-time consultation, or do ongoing care for others. We also, in the last 2 years, have developed a relationship with Vaden. The Adolescent Medicine Service provides ongoing medical care there to allow treatment for Stanford students. And Stanford students can come to us too, and have now. Our main treatments are family-based treatments, which have been now the best evidence-based approaches for adolescent anorexia and bulimia nervosa. We do cognitive behavioral therapy for bulimia and for older patients with anorexia. Interpersonal therapy is offered for bulimia nervosa because there's evidence that it's useful. More recently, Deborah Safer in our adult division has been doing dialectical behavioral therapy for binge eating disorder. Those of you who might have been here last year heard Kara Fitzpatrick talk about cognitive remediation therapy. This is a therapy that really aims at trying to change underlying thought processes, not specific to eating disorders, but that kind of track into that same kind of dimension that Dr. Steiner was talking about in terms of over-focus to the neglect of seeing the big picture, and sometimes an inflexibility when flexibility is needed in terms of being able to shift one's attention to problems outside of the highly focused ones. We also provide medication treatment, ongoing medical monitoring and consultation, and nutritional monitoring and consultation. The length of stay is actually 9, not 12 now, I was told, so this slide needs updating. But the focus there, although on medical stabilization, is a psychiatric milieu within a medical setting, and it's an amazingly unusual and wonderful program that we have. Rare in the world. There are only 3 or 4 such places that I think can take care of such medically ill patients while still providing them with psychiatric support. The milieu consists of a school as well as, so these are often kids who really want to keep going to school. They're usually pretty high achieving kids. As well as the crisis that's evolving in their families is addressed with this development of an eating disorder. This is a picture of a lovely room where our multidisciplinary team talks about the patients and how to best help them on a daily basis. These are other pictures of the unit where the dining room and the school, that's the books. I don't know, maybe soon there won't even be books, they'll just be little Kindle shelves. And there's a patio there, which is a luxury that we didn't have for a while after we left Packard, but now is back. This just tells you how busy we are. We've remained a very active program over many years, and as you can see, the length of stay dropping over even the last several years. Why is that important? Because it's not normal to spend time in the hospital if you're a teenager. It's not really very good for you. The less of it, less is more. But if it's needed, it's needed. We're doing research, and I just want to very briefly tell you about some of the things that we're doing, just so you'll appreciate the incredible support and that Packard and everyone on the team puts forward to not only just providing care, but also trying to innovate around care. We're doing a 6-site study with Canada and 5 other sites in the United States, comparing different forms of family therapy for anorexia nervosa, trying to learn which patients respond to which kind best, and if one is better than the other. For bulimia, sadly, there are only 2 studies of adolescent bulimia nervosa treatment in the world literature. Only 120 adolescents with bulimia have ever been studied in a treatment clinical trial. We're doing one here at Stanford and the University of Chicago that we're still enrolling in now. You heard me mention about cognitive remediation therapy. We're really interested in this as a sort of pre-treatment so that therapy might be better utilized. And this is a study that is just completing treatment phase, and that's an exciting study. A collaboration with the Australian research group in Sydney. We're looking actually at how low we can go in terms of hospital days if families are ready and taught how best to pick up the ball sooner. Things that we've been doing in other fields of medicine for a long time. This study is actually looking at being able to pick these kids up earlier versus later. You heard some mention of brain process and neuroimaging in Dr. Carlson's talk, and this is an area of research that I've become particularly interested in understanding how the functional and structural processes in the brain might be changed by anorexia nervosa, might actually be predictors or biological markers for recovery and for response to treatment. And those studies are looking at family processes, family brain function, as well as just the patient's brain function. And an interesting study that we're doing is with a group in Dresden is trying to help families more quickly identify a kid at risk using an online program called Parents Against Anorexia Nervosa. So those are a brief summary of the kinds of things that we're doing in terms of research. Thank you.